At the outset, I thank Dr. Ramesh and the organizers for giving me this opportunity to interact. So, we will be talking about how to translate guidelines to practice in terms of nutrition in chronic liver disease. The learning objectives is to provide an overview of the clinical nutrition practice in chronic liver disease. Conflict of interest is none. We all know that, what actually happens in, I won't be getting into a lot of theory with regard to chronic liver disease, but certain components which make it very important for the nutritional intervention and the decision making for nutritional intervention is something that I will focus on. And it's a known fact that malnutrition is something that we need to prioritize for optimizing nutrition interventions. And there's always this interaction between getting to know whether your patient is malnourished for certain reasons. It could be low protein, it could be low calorie intake, or it could be the albumin levels, it could be other nutrient interactions, the treatments. These can lead to malnutrition. It could be sarcopenia, it could be frailty. But there's always that it could be starvation related, chronic disease related, or acute disease related. But you should know that there is always an interaction and an overlap between these three conditions, that they coexist during these conditions. So in this overlap, it needs very important identifications whether your patient is at risk for sarcopenia or already into sarcopenia, at risk for frailty or already frail. So these something make us very important for us as dietitians. What we do is we do the ADME process where we follow the detailed assessment, we diagnose and try to find out what is the etiology and the symptoms leading to that, explain an interventional strategy, monitor and evaluate and reassess so that you know whether the patient is recovering or not. And of course, most of us in the nutrition division, we do follow these guidelines given by ASPEN with regard to various disease conditions, and this is one thing that is told for clinical nutrition in liver disease. And today's presentation, we would focus on this, which talks about liver cirrhosis, or what are the interventions that would always look into this category of patients. And we know that treatment does have these following headings that are followed, that diet and lifestyle modifications is one thing that is focused on, alcohol abstinence for those who are alcohol related, healthy weight loss for those who are obese, monitoring the liver functions with regard to the interventions in nutrition and how it is changing, the impact of medication on their oral intakes could be one of them that we would look into, and of course the impact of surgery or pre-surgical optimization is one thing, and the role of physical activity. What's more important is, yes, in my presentation, we would focus a little on the oral diets that generally are advised to these category of patients. Enteral nutrition, how do we go ahead doing enteral nutrition decision making, and of course the role of parenteral nutrition in these patient population. These are the guidelines which talk about initially what do you do when the patient is on oral nutrition. What is the role of dietary counseling that is required for this? What is the protein? Of course, I really know that it's too small to see. My next slide will get into more focus on what it is about. The protein requirement and how this protein requirement changes from 1.2 to 1.5. High energy intake from going from 30 to 35 kilocalories. And what is the quality of protein that should be focused? Role of BCAA, the recommendation of for BCAA, and what is the quantity of BCAA, 0.25 grams per kg body weight of BCAA recommendation, and the role on the advice required for micronutrient and low sodium advice. Coming into greater interventions or going into the next step of interventions of taking decisions on initiating enteral and parenteral nutrition among patients who have not really satisfied with satisfying the nutritional requirements with oral diets, and so we get into taking a decision on enteral nutrition, and the role of how to do the enteral tubes in those patients who have esophageal varices and how PEG placement would really impact their interventions. This is the gist of the previous slide, where the calorie intake is around from 30 to 35 kilocalories. Protein is from 1.2, changes to 2 to 2.5 in obese obese cirrhotic patients. Sarcopenic patients, the protein increases to 1.5 from the regular cirrhotic patients. And if they are malnourished, it increases. Pre and post-operative cirrhotic patients, it remains to be 1.2 to 1.5 grams and more than 1.2 in critically ill cirrhotic patients. What's more important in the oral diets is avoiding long fasting in these patients and ensuring that there is an advice on the late evening snack, which would help. The rule is that you give a high protein breakfast and a high energy late evening snack in most of these cirrhotic patients to prevent the development of sarcopenia. Although it is there, the progression can be delayed. Multivitamin advice can be done, and of course folic acid and B12 if anemia is present. The most important factor is the trace elements, zinc and selenium, which becomes an important factor to be given because most of them are malnourished and require, and the prevalence of or the presence of dysgeusia is another thing which could indicate that they have zinc and selenium deficiency. And of course, previously told, the BCAA recommendation is 0.25 grams per kg body weight of BCAA recommendation. But what is more important is the assessment should be able to identify whether the patient is able to satisfy the traditional protein requirement. Over and above that, you start telling about BCAA. Just giving BCAA by itself really does not work. And this is what is the rationale behind giving a late evening snack, that you prevent the catabolism among these patients and then increase the amount of body proteins. There have been many studies which talk about the late evening snack. The recommendations say that the late evening snack should contain at least 50 grams of carbohydrate, because the main aim for having a late evening snack is to provide a high energy, unlike the breakfast where you focus on a high protein requirement. And the studies also prove that providing a late evening snack does increase the nitrogen balance, protein turnover, the glucagon levels are reduced, fat oxidation is reduced, urea production is reduced, muscle mass improves, and of course the overall quality of life also improves. There is always this misconception that patients with cirrhosis and ascites need a stringent fluid restriction, increasingly aggressive sodium restrictions. But then, yes, that's always a myth, but counseling is needed for them to know that there has to be a restriction to salt and of course fluid restriction only when the serum sodium level is below 125. So that is what is this guideline saying, that the salt restriction is around 2000 sodium restriction is around 2000 milligrams, translating to around 4 to 5 grams of salt, and this is what is there advised. And of course, patient education is the most important thing with regard to compliance to salt usage or fluid restriction, which if it is there, and how do they identify in their day-to-day activities on how to indicate what foods have salt, sodium, or what foods don't have, and how do you actually go into getting to know this. This is what is about, and it becomes a very important thing. Coming down to the functions of what a dietitian should be doing, be it cirrhosis, be it any kind of liver diseases or any diseases in the hospital setup, these are all the different functions which actually tell about the functions of a dietitian. Starts with screening, a detailed assessment, diagnose if your patient is malnourished or not with regard to the diagnosis of the medical diagnosis, develop a care plan, implement the care plan, and that's very important, and it doesn't get over. The most important factor that is there is monitoring and evaluation and reassessment of the patient so that you get to know what is the improvement or how good is the improvement. And there is this saying which says that if you cannot measure it, you cannot improve it. So that applies to us also in the area of nutrition, that you need to measure every step on what we are doing to see whether there is an improvement or not. Coming to the nutrition care process, the whole thing which I explained, what is more important is patient monitoring to see whether there is an outcome or not, or the outcome is better or not. At AIG, we do all this. We have a nutrition screening where we screen and a yes to anything. It's a very simple thing. MST is something that we use. So we do this, and a yes to it leads us to use a detailed format. This format we've been lately using where we follow the GLIM. And of course, additional to this, we do the body composition also where we categorize the patient according to GLIM. GLIM is Global Leadership Initiative for Malnutrition, which has come up in 2017, which includes the traditional assessment formats where you can have objective and subjective measurements for categorizing your patients as being at risk for malnutrition or malnourished, severe malnutrition or moderate malnutrition. And of course, sometimes we need to have a 24-hour dietary recall to categorize your patients as regard to what is the percentage of intake that they are taking. It could be more than 75%, it could be between 75 to 50%, or less than 50% of the recommended food intake that they should be taking, and then categorize the patient as being at risk or not at risk. And of course, pertaining to this, we do have the RFH screening tool, assessment tool, which you can actually use to categorize your patient as being malnourished or not. This is something very important for us to know, that you monitor the tolerance and adequacy to what you've actually advised. Advising nowadays is not a big thing. You can always say 80 grams of protein and 2,000 calorie diet. That anybody can do. But monitoring whether your patient is actually having that what you've recommended is more important. So you have to really know. See, like if you see, this is the format that we follow. This is a physical copy. Now we've gone to EMR, so it's all done online so that everybody gets to know. If you see, the oral food or the feed volume is specified there. And then the others also give us about any remarks on what is there. It tells us about whether the patient is on NG feeds or whether the patient is on an ONS. These things are told to us. Additional to that is the second level where we talk about the interruptions and what are the reasons for interruptions. Is it like vomiting? Is it the patient having diarrhea? Is it an absorption issue? These are things which tell us, has the patient been put on NBM for certain diagnostic procedures? This happens on day. Every day you need to fill this to know that you've recommended or advised a 1,000 calorie diet or a 2,000 calorie diet, of which how much has been actually taken by the patient or provided to the patient. Anything that is less than 50% to 60% of the recommended intake, then the next level of nutrition support is generally advised. It is enteral nutrition or sometimes supplemental parenteral nutrition or sometimes exclusive parenteral nutrition with enteral nutrition too. Coming to the oral diets, yes, we do show them different formats of different diets, tell them how they are, they get to choose what they are. Anybody that does not meet the recommended oral intake of any of these plans which are given to them, then an oral nutrition supplement is advised to them additional to their oral intake to meet not only the energy and protein requirements, sometimes it's also the micronutrient requirements. Coming to the enteral nutrition feed plans, this is how we actually place in our institution. We start off, no matter what is the condition of the patient, we start off with giving a 25 ml feed to check for tolerance. And we put the diagnosis like this, where we say what is the recommendation, what is it coming from the feeds, what is the recommendation of protein, what is the amount of protein coming from the feeds for that day, and then what is the sodium and potassium content. If your patient is a diabetic, then the carbohydrate percentage is also put. And then this is for taking forward the multidisciplinary approach, where every individual who is working with the patient gets to know what we are doing in terms of nutrition. And once the feed volume is increased, of course, the second product comes into picture, and then we put another product. Similarly, we give in all the details that are pertinent to the rest of the working team. And not only this, there are some oral patients who are also on enteral nutrition along with an oral diet. So we have this concept of what is called as an intermittent diet, or where they get a free time to eat during breakfast, lunch and dinner, but in between we give them an enteral nutrition to compensate for the nutritional requirements. So this is what is again there in the case sheet, We put it up there for the other members to know what we are actually advising. And of course, the monitoring sheet will tell you how much the patient has actually eaten. So this is to compensate for their requirements. And of course, not to forget, this is something that it's not one person's duty, but everybody in charge of the patient who talks about exercise. There is a recommendation about exercise, and that's the role that we need to stress upon along with nutritional intervention, for nutritional intervention to work on. Because preventing sarcopenia, exercise is one good thing. No matter your patient is in the ICU and you're giving 120 grams of protein, 150 grams of protein, because they tell me that you give you that, but if there is no exercise for your patients, this is of no use. So nutrition becomes of no use when that is not combined with exercise. And this is the recommendation, which I'm sure all of you all know about these recommendations, and there are a great amount of advantages of having the exercise. In conclusion, clinical nutrition is an important part of patient care. Nutrition therapy has evolved from just a supportive tool to a therapy that requires close attention and monitoring. Create a culture where all stakeholders value nutrition. That's the most important factor, because I'm the dietitian and I would want to stress on that. Redefine the clinician's role to include nutrition care. Recognize and diagnose malnutrition patients and those at risk very early so that intervention can be started very early. Implement comprehensive nutrition interventions and monitor continuously, because monitoring is the most important factor to say what next for that patient. Communicate your nutrition care plans, develop discharge nutrition, and in fact, discharge starts with the day of admission for us, where at admission we already know what plan we should be having for this patient in terms of the prevalence of malnutrition among those patients, on how to talk about discharge education plan. Thank you, and this is my team who does that.